Good morning, good afternoon, good evening. It is with great pleasure that I welcome you all back to the Lancet Commission on Gender and Global Health. And I'm delighted to introduce today Professor Gary Darmstadt, who many of you watching this live stream will know Gary's work in relation to the seminal Lancet series on gender equality, norms and health, which came out, I think, 2 years ago, Gary. I'm sure you'll correct me.
May 29th.
Almost 2 years to the date, to the day. Yeah. And really form some of the basis of the work that we are now looking at in the overall Lancet Commission on Gender and Global Health. So by way of a very quick introduction, my name is Sarah Hawkes. I'm a Professor of Global Public Health at UCL and one of the co-chairs of the Lancet Commission, along with Professor Pascal Alotti, who is at United Nations University in Kuala Lumpur, and Asai El Haj, who is based in Dakar, Senegal. So without further ado, I will hand over to Gary Darmstadt, who is Dean of Maternal and Child Health at Stanford University, an expert in maternal, neonatal and child health, previously leading the Gender Equality Initiative at the Bill and Melinda Gates Foundation, and as you're about to hear, an expert on gender equality, norms and health. And for those of you watching on live stream, if you do have any questions, please put them into the chat below the screen so that we can, or below the video, so that we can actually leave some time for Gary to answer those questions at the end of his talk. Gary, thank you. Over to you.
Great, Sarah. Thank you very much. It's really great to be with you all. Thank you so much for joining. It's been a lot of fun for me 2 years out, as you said, Sarah, to look back on the series and what we learned. If we can get the first slide up. Go ahead and go to the next slide. So this was a series that was comprised of 5 papers, and there were an additional 40 supplemental papers that have come out, which I've listed at the end of my slide deck, if you care to look at those that have built on what we described in the Lancet series. This was a massive collaborative effort. We had 114 contributors from 41 organizations, I believe, across 5 continents. This was funded by the Gates Foundation and by the United Arab Emirates government. Next slide, please. This just shows the places from around the world that our collaborators came from. Next slide. And just to acknowledge, many of you in the audience, several on our Lancet Commission were part of this effort. So what I'm presenting is really a large collaborative effort. And what we really aimed to do was to describe the rigorous evidence that exists for the impact of gender inequalities and restrictive gender norms on health. And we were really trying to focus in on the normative elements that underlie gender inequalities and that really stretch across the whole range of inequalities that we see. And as a result, we were looking for opportunities that exist to be disruptive in the systems that hold up these norms that perpetuate these gender inequalities. So opportunities within systems, within specific programs and policies. And we really aim to inspire some new conversations and hopefully some new methodologies to address and understand ways in which norms impact health. I'll be going through briefly each one of the 5 papers shown here. Next slide. So norms are the unspoken rules that govern our behavior, that tell you what is acceptable for you, that's acceptable for males and females, and these influences come from all around us, starting even before we're born, within our family, within our social circle, within the institutions that we take part in. And the norms that we're sensing end up being expressed in our attitudes and in our behaviors. Next slide. We view gender in the context of a system, and really with a focus around the power, the resources, the roles, and the social status that are bestowed upon you by that system as a result of the perception of your maleness or femaleness. And this system is upheld by norms, and there are prescriptions against deviating from those norms. And thus these norms act upon us as individuals, shape our standing in the world, shape the opportunities that we perceive that we have. Next slide. The first thing that we did was to develop a conceptual framework. And these are some of the main elements that we sought to express in our framework: that sex relates to health differences, whereas gender, a socially constructed description, relates to health disparities. And that this all happens, the generation of gender happens within a system that is socially produced. And gender intersects with many other factors, many other social determinants of health that give us a place within society, and that leads to social inequalities and power differentials that we're navigating. And it's in that navigation that we enter into the health system and find that health system encounters us and treats us through our gendered status, and that this ends up leading to disparities in health. And so we set out to show those pathways whereby gender ends up leading to these disparities in health, and ultimately to convey that gender inequalities can't be addressed without transforming gender norms. Next slide. So this briefly shows you that construction. We have sex as opposed to gender at the beginning of the on the left-hand side, showing the kinds of institutions that are part of the gender system and that lead to the social production of gender. We show the interrelation with other social determinants of health that give us our gendered social position. And then the 5 pathways that we described through which inequalities in health are generated as we interact with health systems. These are gender differences in exposures, in health behaviors, in differences in accessing care, in differences in the way that the health system interacts with us, and the ways in which our health research institutions and data collection systems are biased and perpetuate these norms. All of this leading to health inequalities and ultimately to the embodiment of the discrimination, the imprinting of this discrimination upon us, leading to a lifetime burden and effects on our health. Next slide. So in summing up the first paper, we talk a lot about the hierarchy of power and privilege and the reinforcing elements that of inequality that the system is constantly putting upon us. Historically, these inequalities have fallen primarily on women and girls. But when we look at it through a normative frame, we find that restrictive gender norms impact all of us, undermine the health and the well-being of all people. And that it really becomes clear that a binary sex indicator, our basis for sex disaggregated data, really falls short. It really prevents us from understanding gender in its social context, from really understanding the normative influences that are affecting all people. Next slide. The third paper in the series was trying to understand what is the impact that programs and policies have had on shaping norms and thus on health. There were 2 basic elements of this work. One was a systematic review of the peer-reviewed and the gray literature for rigorous evaluations that looked at gender transformative programs and also measured impacts on health. And in most cases, they also measured impacts on gender elements. And then we conducted a policy analysis comparing countries that had instituted a policy for tuition-free primary education or paid maternity and parental leave. And we compared longitudinally the various health indicators in countries that had the policy and countries that did not have the policy, controlling for various contextual factors. Next slide. We found that we found overall 85 programs that fit this description. 61 of them focused on adolescents. And as illustrated here, these programs, I would say, were all over the place. We tried to look at what are their activities that they implemented, what did they measure with regard to gender, what did they measure with regard to health outcomes. 98% of them did implement some awareness raising component, and 87% focused on community engagement and building social support systems. 56% of the evaluations focused on activities to improve your internal locus of control as you raise your awareness and you try to navigate gender norms within your system. Next slide. The systematic review can be briefly summarized here and reflects the bias that exists in the literature. And that bias is that norms and gender inequalities, again, primarily affect women and girls. There's a focus in the literature on family planning, on reproductive health, on violence against women, and on HIV. 90% of studies fell into this category. Although there were other health indicators that were evaluated, this really was the focus. 3/4 of these programs showed significant improvement in indicators of health, as well as indicators of gender norms. And we found 10 programs that were working across sectors that measured multiple health outcomes and showed effects at once, that showed evidence of sustainability and evidence of scalability. A really high bar for these 10 studies. And the characteristics of these high quality programs were that they worked across sectors, that they worked across stakeholders, that they had diversified approaches to their programming, and that they really engaged communities to participate and to be empowered in recognizing and reacting to the norms that they're sensing within their community. Next slide. These are the results with regard to the two policies that we looked at. We looked at indicators for family planning and skilled attendance at birth and child immunization. And as you can see here, in both cases, for both of these policies, in countries that implemented the policies over time, there were marked improvements in these variety of health indicators. Next slide. We furthermore found that for every 10% increase in educational parity, there is a 2-year increase in female life expectancy and a 1-year increase in male life expectancy. And this really illustrates the notion that addressing norms, while those norms affect all of us, the addressing of those norms also improves the opportunities, the health, in this case, the life expectancy of everyone. We also found that a 10% increase in the work parity index or a 10% increase in female labor force participation was associated with a 1-year increase in female life expectancy and had no effect on male life expectancy. So some super strong quantitative evidence of the impact of programs that transform gender norms and policies that transform gender norms, impacts on a wide variety of health indicators and even life expectancy. Next slide. Looking now at data, and I have here the tagline, sex disaggregated data is not enough, which I think will illustrate well as you read this is the second paper in the series now. Go ahead and go on to the next slide. And we developed an approach where we first of all identified some kind of a disparity in a health burden. And then we identified proxies for norms that generally reflected an attitude or a behavior of some group. And we had to find clusters of people so that we could compare them. And we had to understand through that clustering who was the reference group and how did people interact with that reference group, trying to understand who's enforcing the norm. And where does the impact on health come from? We were then able to develop a specific hypothesis to test about how health was being influenced by gender norms. And then we applied statistical analyses to each of these case studies. And so we developed 6 case studies. Looking back, we actually developed about 20 of them, but we ended up highlighting about 6 of them. That looked across the life course and it looked at a whole variety of health outcomes and a variety of geographies, really reinforcing the point that norms are affecting all people everywhere. Next slide. Just to give you one example related to HIV, and this is trying to understand why is it that adolescent girls have about 3 times the risk of HIV acquisition compared to adolescent boys. Next slide. We found a particular opportunity, I think really a model within the DHS that existed for 2 years, where they asked a series of attitudinal questions. And in this case, should young women or should young men wait for sex until marriage? And they asked these questions of men and women about men and about women. So it was a very balanced set of data, which provided a real unique opportunity. Go on to the next slide. Here we see the attitudes, and in this case, we show male respondents for men, females for females. Should men or women wait for sex? And in general, people said, yes, they should wait. There was some variability here, but not enough analytically to really do that much with. So then go on to the next slide. We then constructed a variable, and this wasn't asked of people, this was constructed a variable of did they wait for sex? And we did this by looking at the age when they said they first had sex and the age at which they first got married, and then derived whether they waited for sex before being married. And here you see much more variability that starts to emerge. Go on to the next slide. And here we focus in on Zambia, where you can see a wide disparity between what people say you should do and what our calculation of what they actually do. And we began to think that there's really something here that we have to take a closer look at. And it may be that this discordance, as we described it, between what people say and what people do could create a normative force within the community that places girls at a particular risk. Because you see here a double standard. It's pretty much applied across the board. People should not have sex before marriage, but many more women do wait than men. Go on to the next slide. So we constructed our hypothesis kind of like this, where adults in the community are saying youth should not have sex before marriage. But people are saying, well, but we had sex before marriage. And they're saying, no, we don't talk about that. And the adolescents are saying, we don't talk about sex. I don't know about safe practices because I am afraid to go out and seek that kind of information and certainly services. And as a result, because of the double standard, adolescent girls are at a higher risk than adolescent boys because of unprotected sex. Go on to the next slide. So this is what we found when we looked in Zambia at a regional level, looking at the y-axis is at HIV prevalence, and on the x-axis at the degree of discordance between attitudes and behavior by province. And as you can see here, quite a strong relationship between, as the level of discordance went up regionally, the HIV prevalence went up with it. Go on to the next slide. So what we found is that this discordance between attitudes and practices explained 20% of the variation in HIV prevalence for adolescent girls. We did not see this relationship for boys. So it appeared that this taboo gap was applying to girls and not boys, and the prohibition upon seeking services was primarily affecting adolescent girls rather than boys. And this has important programmatic relevance, and that the power dynamics and the sexual double standard increases women's burden of health inequities as they perceive that disapproval from the adult reference group in the community. So this is one example of where we use quantitative analysis and use that structure that I described to gain some insight into how norms may be affecting this aspect of health. We're now going on to look in the qualitative, in the literature. We're doing a literature review on this topic, and we found a lot of evidence to support the existence of this taboo gap in Zambia, and we're going on to do some additional quantitative analysis. Okay, go ahead and go on. I'm going to advance the slides here a little bit, just given the time. Go ahead and keep going. We have many really interesting examples, and I would refer you to the second paper in the series for those. Keep going on. Go ahead, go on. We're going to go on. Go ahead and go on. Just to go back, just for one quick moment. I think it's really important to highlight the elements of bias in gender-related data that we found during our Lancet series evaluations, elements of missingness, imbalance, and bias. I've listed several of them here. I won't take the time to run through each of them, but I just flagged this as a really critically important area where further analysis is needed to really understand the ways in which missingness, imbalance, and bias is embedded within our data systems, and that end up influencing the conclusions that we're able to draw from that data. And we found many examples of each of these. And a key one also being that we found that the intersectional analysis that we really aim to be able to conduct is really limited by our current data systems. Go ahead and go on. Looking now at systems, and here a rather busy slide, but I'll summarize this quickly to say that we found a lot of evidence that our health systems reflect the gender inequalities, the gender discrimination and biases that exist in societies, that it gets recapitulated in the care that's provided and in the way that the system views and approaches people who come into the system for care. We describe a care versus cure role, women being kind of pigeonholed into care roles that are valued less, that are compensated less, that have less power and influence within the system. And men are put more into cure roles with greater leadership, greater influence, greater pay within those systems. And that this leads to poorly performing systems for everyone, ultimately. Leads to job dissatisfaction, burnout, the marginalization of people within that system. We described it as a kick down to kick out phenomenon, where the lower your social gendered position and intersecting with other aspects of disadvantage, the lower you are within the system, the poorer that system meets your needs, to the point that you ultimately get kicked out of the system and it doesn't serve your needs at all. Go ahead and go on to the next slide. We found a number of ways in which health systems and systems more broadly could be disrupted in order to create opportunities for greater gender equality and addressing intersectional disadvantage. Social movements being one, with accountability from the community into the system. valuing frontline workers and providing and helping to ensure family support, community support and respect, opportunities for advancement. These things improve the performance of frontline workers. And then mobilizing civil society and holding leaders to account, being a very potentially powerful force here. Let's go ahead and go on, and I'll summarize now. Our fifth paper. So in the series, we described and debunked these three key myths about gender norms, that gender norms don't influence health outcomes, that they're entrenched and can't be changed, and that they're elusive and can't be measured. All of these things are very untrue. We found a number of persistent barriers to progress: gender bias within systems, inadequate response by governments. And here we talked quite a bit about mainstreaming efforts and the ways in which they need to be more focused on outcomes rather than process. Gaps and bias in our data and in our health research, lack of funding for women's movements and for civil society actions to address gender inequality, and corporate interests that there's very little to hold them to account currently. Next slide. So we called for a number of actions, focusing on outcomes, health and gender equality outcomes simultaneously rather than process, to actions that would stimulate the health sector to work collaboratively with other sectors. We can't address the social determinants of health that underlie gender inequalities and intersectional inequalities without engaging with other sectors. Creating a safe workplace, an equitable workplace, building a pipeline of health professionals that understand these issues and know how to address them. And we called for a workforce, essentially, that can come alongside organizations and help them to take a gender lens, let's call it, and to embed gender into all considerations and measurements that they make. Next slide. Strengthening our measurement systems, reducing bias in our data systems, empowering civil society actors, and then the real importance of transparent accountability mechanisms that also have mechanisms for remedial action to really hold people to account, including corporate entities. Next slide. And then finally, that ultimately it's all political. We list some political priorities here. On the right, ultimately, this isn't a matter of lack of evidence, of the need for more evidence. It's really a time for political action and holding people to account for the fundamental human right for gender equality. Thank you.
Gary, that was fantastic. I mean, it was an incredible reminder of the vast scope of work, and not just the breadth of work, but the depth of work that went into the series, and the huge variety of papers that and the huge variety of evidence that was presented. So thank you for giving just a brief taster of the richness of those 5 papers. I really appreciate that. I wonder, whilst we're waiting to just gather any questions from the YouTube channel, I wonder if I could just start off and ask you to reflect on the overall impact of the series, and whether, you know, it is 2 years, which probably it seems like it's been a very long 2 years for all of us, but in reality, two years to see and measure change is a relatively short time. But given the series and given the absolute rigor and volume of the evidence produced, what kind of an impact do you think we might expect to see in the short and medium term?
Yeah, thank you, Sarah. We haven't systematically tried to capture the answer to your question, and it's something that I've often thought about. I do think that some of the analytic work and I think some of the innovative ways in which we thought about understanding how norms impact health and what that means for gender inequalities, I think was really important. We're continuing to write about that and are hoping to increasingly see people take that up, because these are methods that can be widely applied by epidemiologists all over the world. It just takes some interest. These data sets exist. While they don't have specific norm measures, they proxies can be created. And so this is one thing that I think is beginning to have some impact upon people, that we have tools, we have ways of really describing and hypothesizing where norms are having adverse impacts and gaining some further insight into what programs need to be doing. I think that the ways in which we thought about bias, missingness, imbalance in gender data, I think is a new part of the conversation. I think up until this series, mostly what we would hear about gender-related data is that we need more data on women and girls. And in fact, I think what our analyses have shown is that we actually need more data on everyone, and we need balanced data on by age, by gender. We need data that enables us to look into intersectionalities in a quantitative way. And I think that this is something that I think really has begun to enter into the discourse and begin to get us beyond, the earlier discourse around women and girls, and getting us to think more comprehensively about the gendered dimensions of our data much more broadly, and the fact that this is impacting all of us. I think we certainly have, and not to try to take credit from the series, but we certainly have seen that the political nature of gender, of intersectional discrimination, has really come to the fore. And I think that the timing of the series was fortunate in that sense, in that, hopefully some of the learning, hopefully some of the methodology, hopefully some of the things that we're calling for are entering into the discourse that is now all around us, that we're all confronting within our workplaces, within our societies in ways that we've not seen before. So I think that the timing was excellent. I've, as I mentioned, I've thought about trying to capture that learning, and maybe based on your question, maybe I'll be stimulated to do that a bit more systematically and hear from you all. You're the ones who I think should be answering, this question: how has this influenced you? And I'd be really interested to hear that.
Thank you, Gary. I mean, perhaps that can be a stream of activity for the Commission as well. So we've got a number of questions that I will come back to you with, Gary, but I realise that we've actually run over time as far as the live broadcast is concerned. So I'm going to say thank you very much to everybody who did join us on live broadcast, and please tune in again in 2 weeks' time. And Gary, if you could stay on this platform with everybody else, we'll just open up the floor to